We're from the Nova Scotia Health Authority, based out of the Colchester East Hants Health Centre. And the MMS framework shifted safety for us from a policy perspective to a day-to-day care provider and patient interaction. It led to ownership, engagement, and passion about patient safety.
So we came on board last January. We kind of felt behind in the whole process from the start. And I would have told you that I didn't think we would be here last year if you asked me. We've changed little things throughout the process in our emergency room, and now I feel like we're in a totally different spot just by being who we are, leading what we're leading, and using the framework every day.
The accomplishment that stands out most to me is one that's difficult to measure, which is ironic given that we're talking about a measurement and monitoring of safety. But the framework has helped us deal with the complexity of our environment in the emergency room. So it encourages us to engage all levels of staff in problem solving. And where we are working in a very dynamic and shifting situation, it allows us to incorporate information from all levels of our team to address daily challenges, monthly challenges, pandemic challenges. It's given us a level of engagement that we haven't seen in our department in a very long time. And again, it's difficult to really measure that on a scale, but we've had feedback from other areas of our hospital that there's a perceptible difference in how our team is tackling challenges and the work environment, which I think is a huge accomplishment given the issues that our emergency care is facing in the present healthcare environment.
I think one of the most perceived impacts is that we're good at doing things. There's nothing we can't do. We always see the challenges come and that's the impossible, but we get around it by using the framework every day because everything's different. No day is the same, no patient volume is the same, no amount of admissions are the same, but it guides us every day moving forward, being able to make a process without making a process, and we include everybody on the front line to move forward together.
Yeah, the perceived impact for me is that staff view themselves as part of the solution. They don't look to leadership to solve problems. They come to our safety huddles with ideas and solutions that they've already come up with. We're seeing staff go out to other areas of our hospital to engage with other teams to gain feedback on our performance and ways that we can improve. A recent example is that some of our more junior staff were trying to develop a description of what a charge nurse in Emerge should be. And they actually took it upon themselves to go around to the different units of the hospital to get feedback from charge nurses on other units on how we can better improve the interactions between the floors in the emergency department, which is a huge leap for our building and our team and the environment in the hospital. If you wanted to know specific things that have, that you can measure on paper, we've gone from a very sort of uncoordinated approach to dealing with things like physician late reports was one of the things that I tackled. We had a situation where there were lab reports and diagnostic imaging reports that were coming back late after a physician had left and after the patient had left, and there was no formal process to ensure that those results were acted on. So you might get a chest x-ray with a finding that would be suspicious for a tumor. And previously someone would take that piece of paper and walk it over to the doctor who had, maybe 20 tasks on the go and ask them to deal with it in the moment. But there was no way to confirm that that had been acted on. There was no way to document what had happened. So there's obviously a great deal of concern that things may be getting missed. And using the MMS framework, we tackled that problem and created a whole new process, which has been very well received. We're getting lots of really great patient feedback on the phone calls that we're making to give patients follow-up on results that have returned to the emergency department after they've left. And this is crucial in Nova Scotia because we have a significant primary care shortage. So about 40% of our patients don't have a family doctor. So in the absence of that process, those patients may, they'd be in a void of lack of feedback of their results.
One of the big things though is I think the way we talk about harm and all the experiences, like years ago you made a mistake and it wasn't something you would talk about. Those are things we talk about daily at our safety huddles now. So we've had instances where something has happened in the department And instead of it just being behind a closed door and vocalized, it comes out at the safety huddles and everybody talks about like how we could move forward. How did that happen to that one person? What can we do to stop it from happening to the next person? So those kind of things shifts people's awareness and engaging the staff and telling us what's actually going on instead of being afraid to tell us those things.
I think the mannitol example is a good one where, staff took it upon themselves to basically investigate how a possible error had happened and came back with kind of their feedback. And
they became detectives and then realized that there was an error in our department with a drug. An IV fluid was hung instead of a normal saline fluid. And the nurses found out about it. They followed the report. There was no harm to the patient. In the end, though, everybody in the department was equally excited to find out how it happened, where it happened, and how it got mixed up. And they talked through it multiple times over. Patient safety is significantly changing every day. We work in an environment that's totally chaos on a regular basis, and we are at high risk for making errors every day that we walk in to the emergency room. We see it all the time, like drugs look the same, machines don't have alarms that maybe should have alarms, and we get used to hearing alarms that we don't answer them all the time, but right off the bat. But now everybody's just heightened, slowly integrating that framework. And I mean, when we started those safety huddles, it was complete crickets in the room. People stared at you, didn't talk, they just kind of listened. And now we're getting an overabundance, like you start them and everybody's got an idea to change something, or this happened to me and that could have been a very big error. And now they address it beforehand.
The perceptible difference in our department is that safety has become something that is about what each individual person does, sees, observes, communicates. And that has changed from something where safety is checklists. And that's been a huge change. And it's not just been linked to, I think, better outcomes, but it has also resulted in an impressive degree of engagement among staff in working in an incredibly difficult environment.
One key point that has shifted in our department is the engagement of all our frontline staff. They want to listen and they want to do better and they want to be the best they can be and treat everybody equally. And so they've really taken it to heart, and they always have ideas now. You can't even stop the ideas that come forward from them now.
There's a degree of personal ownership of safety that it wasn't that it wasn't desired previously, but I think people didn't feel empowered. They didn't feel like what they would feed back to our team would necessarily result in a change. Because of that last step of integration and learning and cycling through the MMS framework, our staff see that when they give feedback, it's acted upon, and they get that, they get that information back about what has happened or what has resulted from the information that they've given. So now people feel like when I state my concern, someone hears it, someone acts on it, someone gives me the feedback about what's happened or what's changed or how we're going to address the concern.
What we've seen change at the institutional level, I feel like I'd have to take a step back and say that through this process, we all developed a new lens and a new way of seeing safety. It is very hard to integrate into another part of the system that doesn't have the background behind the MMS framework. So there's a bit of struggle because the way you see something, it's like your glasses are a little cleaner and you can see harm before it actually happens or safety effects, but there is a process that you would need the knowledge behind. So there is a bit of a gap between what happens in our emergency room and elsewhere in the system right now.
Yeah, but we are seeing the MMS framework spread. I think the best example is that we have a pharmacist who attended one of our quality meetings, which is naturally a place where MMS discussions happen. And she was so impressed by the discussion and encouraged. She emailed us just regarding her, impression of the meeting and how positive it was and how much positive change was happening in the department. And she sort of alluded to I know you guys said it was all about that framework, but you're obviously doing something right. And the truth is it really is about the framework. That is what's changed. And so she's very interested in learning about MMS and interested in bringing that to the pharmacy team. We have another team member who's moved on to our surgical unit. They've initiated safety huddles. We've started to engage with senior leadership within our building to talk to them about the MMS framework and start using it to look at issues of overcrowding. So it is spreading slowly, but I do think that a key to being successful with MMS is not to view it as a discrete package that you start and finish. It has to be something that grows from the bottom up and spreads naturally. So what we do is we talk about it, we share our passion. When we have the opportunity to have conversations or introduce the framework to others, we do. And I think the strength of the framework speaks for itself. So people are seeing what's happening in emergency despite our challenging environment, and they're interested, they want to know, and they want to learn more about the framework. I think the way that leadership supported us was they took the leap in sending us here. That's really, they were willing to take a risk, embrace something a little different than what is typically associated with the harm reduction model in hospitals. And they supported us in coming here. As far as really engaging in the MMS framework, the NSHA has a lot of issues on its table right now. And so not that safety isn't a priority, but I'm not sure that they have had the time or ability to really engage in the framework. But I think that they're listening, they're interested, and I do think that as we see more and more improvements in our department, the idea and concept of the framework is beginning to spread upwards.
The first cheerleader that brought us on board is Debbie, because she got the project and it was given to another team within the hospital. So we dove into it in January, another fit, and I guess our leader, Heather, our manager, was the one who really gets passionate about all this stuff, and she brought it in and was like, this is a great project. And I think she contributes to a lot of what has happened here because she holds the bar high for safety, and it's completely high, and we stay here and there's no standard that's going to diminish. And she pushed us sometimes even when I think we were like, oh my gosh, this is too much, but I think it would go to her a lot.
Yeah, I think persistence is the key. You need somebody who's passionate about it and who's willing to bear through the crickets. So as Tammy said, when you initially start safety huddles, the concept is just often so new, it's very difficult to bring anything to the table. So you have to kind of persist, sometimes for months, at those safety huddles and meetings. I had my first safety huddle with the physicians recently, same thing. Just the concept is so new that what really brings a team together is just tenacity to stick with the framework, continue using it, continue talking about it. We talk about in our team how using the MMS framework is like a pot that you put on the stove. When you initially put it on the stove and you turn the heat on, it doesn't look like anything's happening, even though the temperature is rising in the water. And so for us, there were months of just nothing happening in the pot. But we keep having the conversations, we keep framing questions in different ways, we persistently share the framework with others, and then you start seeing bubbles, and now we're at a rolling boil to the point where it's almost difficult to manage what's coming at us. So I think the key to a team being successful with the MMS framework is just having a plan, having a vision, and staying the course.
We use MMS every day when we walk through the door, and it continues around the clock. It's something that we have to do because we never know what volumes we are going to see, who's going to be in the department, when they're going to be in the department, and what we can flow out of the department. So we are constantly always evaluating every hour almost who's there, regrouping with the team, how we're going to move forward, what's the plan for the next patient, how are we going to settle the next ambulance, and be ready for the next big event that's going to come through our doors.
Emergency medicine is all about preparedness. So the idea with the MMS about looking toward the future and trying to anticipate instead of looking in the rearview mirror really matches nicely with being ready for that emergency that may walk through the door. So I would argue that in our day-to-day work in the department we use the MMS framework, but we also use it in our meetings, in our conversations with others, in our written communications. We always use the framework to package whatever it is that we're talking about, and that was intentional. It started right after our first initial attendance at a meeting to be sure that because we felt like the way to get the language out there was to just start using it all the time.
The sustainability of it happening in the emergency room, I think, is going to continue. The nurses are all engaged, developed resilience, and they're ready to move. They have ideas every day. I'm not sure that we would be able to do it in a different hospital. I'm not sure. You can mimic this everywhere, but it is part of the team and their engagement and if they want to do it.
I think once people see the value in the framework, they use it. And that's what's happened, is that there has been Again, that moment of the pot boiling, a switch is flipped and people see the value of the framework and the benefit to the patients and the benefit to the work environment and how they feel about their job. So I think that you need leaders who are willing to encourage the time to be able to do the safety huddles, who are willing to receive feedback about safety concerns and act on that feedback in a way that staff are satisfied with. But I think we have all the elements right now to see sustainability, so that I think, once the staff see that it's benefiting the patients, because that's what they're there for, is the patients, and that's where the passion is. Now that they see that the patients are benefiting, I think it would be hard to stop it at this point. We're engaging patients and families through the conversations that we have around safety issues. So we have essentially a safety database where potential events that may be harmful or could have potentially been harmful to patients are entered. And either our clinical manager or myself as physician lead will contact patients and have conversations around things that have happened, either because the patient has fed back that they're not feeling like their care was met their level of expectation, or that staff has reported that an error has occurred. A particular situation was where a patient was harmed due to our overcrowding. There was a day where there were 20 patients in our waiting room. We had a full hallway of ambulances. Our department was completely full and bed blocked. And that patient had to delay in care. That didn't result in direct harm to the patient, but was perceived as harmful to the patient. And so our manager, Heather, met with the patient at length to just discuss her view of what had happened, how she had been harmed, and to try to talk about ways to address that in the future. Again, in the emergency room, we can't control who comes through our door. And so there's no perfect answer to that patient's particular situation, but I do think the patient felt heard. And certainly we took to heart her message of her experience in the department, and we'll try to incorporate that as best we can given the circumstances.
Our thoughts on this framework are that it's good, it's solid, it's a great way to get people engaged. It really does work. You can't look at one part of the system all the time. We live in a system that has focused so highly on past harm that really you can make changes sometimes, but when things come down and say you don't do, just from one instance, everybody's different, every patient's different. So what might happen to you is different than someone else. So when you actually use the framework and dive down, you walk through those areas of past harm and reliability and how we're going to prepare it for the next. And it gives people a judgment call on how to move forward and process a patient, or put somebody in a different area, or treat someone, or change their care, or make it more personalized.
I would advise another team to come in with an open mind, be prepared to struggle, be prepared to hear crickets when you talk about the framework with other people or introduce it to them, but to be persistent. And I would say that healthcare is a very complex environment, and in order to tackle complexity, you need a variety of players giving feedback and input and acting, particularly if you want to be nimble in a challenging or changing situation. And what the MMS framework gives you a roadmap to do that. And so I would say that in a very difficult time in healthcare, this has brought a very positive change in the culture in our department. It's brought a vibrancy and a degree of engagement that we haven't seen in a very long time, despite seeing unprecedented numbers and facing challenges with complex, chronically ill patients. We've been able to implement this without extra resources, without extra people, all you need is to have an open mind and a team that cares about the patients. And I think in almost every healthcare situation, you're gonna have that. I would recommend that if you want to implement this framework, you take a group of passionate people who are interested and open-minded and send them somewhere to learn about the framework, and then give them the room to do the work. And as I said before, you cannot implement this framework from the top down. You'll fail. It requires engagement on a grassroots level in order to be successful. And then you just let it happen, because once it starts happening, other people are going to see it happening and want to get involved. Here's why you need to start at the ground level, at the bedside with the MMS. Patient safety ultimately is an interaction between the immediate environment and the provider. And so safety cannot be implemented from several organizational levels up. If you try to dictate via email patient safety, it doesn't translate. What translates is human interaction, the interaction with the environment. And so the MMS boils it down to that ground level of the provider, the patient, and looking in that environment with a lens to safety. And it certainly needs supportive leadership. We need the right equipment, we need the right amount of money to pay for staff and funding, but you don't have to have that. You still can use the framework even if you don't have that. And that is the key, and to try to email your way down with the MMS framework, or PDF your way down to the clinical level from a higher level, it's doomed to fail, because people have to understand the framework in how it relates to yourself and the patient and the area you work in.